Good afternoon, and thanks for joining us on today's webinar to discuss the findings of a new report, Improving Child and Community Health, Addressing Workforce Challenges in Our Community Mental Health Center. I'm Kim Firth, Program Director at the Endowment for Health. The Endowment is the state's largest health foundation and for nearly a decade has invested in transforming our children's behavioral health system as one of our major priorities. This has included significant investments in workforce development. Why? To quote Joan Dodge, national expert on children's behavioral health and workforce development, workforce stands at the heart of transforming mental health delivery systems for children and families. Without careful attention to ensuring the presence of high-quality workers who are prepared and trained in the skills and competencies needed to work in today's environment, the task of change becomes difficult, if not impossible. On today's webinar, we'll hear from Dr. Joanne Malloy from the Institute on Disability, who has led the Children's Behavioral Health Collaborative's Workforce Development Network. This network has been the catalyst for this new report. We'll also hear from Dr. Peter Antal from Antal Consulting, who will talk about the methodology used and the findings in this report. Next, we'll hear from Jody Labarsky, Children's Director from Seacoast Mental Health, who will reflect on the report from the Community Mental Health Center's perspective. Finally, we'll hear from Effie Malley, Director from the New Hampshire Children's Behavioral Health Collaborative, about next steps. And, of course, we'll save a few minutes at the end for your questions. But please feel free to ask your questions throughout the webinar. All participants are on listen-only mode. Today's webinar will be taped and posted on the Children's Behavioral Health Collaborative's website. If you need help with a technical problem, please go to GoToWebinar at 855-202-7963. Throughout the webinar, you can enter questions in the control panel on the right-hand side of your screen. Click the orange button to display. We'll get to as many questions as possible during our question and answer session. Finally, the summary and the full report is available in the handout section of your control panel. So without further ado, I'll turn things over to Dr. Joanne Malloy.
Thank you, Kim. It's a great honor to be here and to have a chance to present to all of you. And I really want to thank the Endowment for Health and our other sponsors with whom we've been working for a good 6 or 7 years at this point now. The Children's Behavioral Health Workforce Development Network, and I apologize for the length of the title, but it's very descriptive, is a collective of individuals from practitioner groups, the Children's Mental Health Centers, and all manner of providers, as well as family organizations, policy folks from the state, as well as a broad coalition of people who are interested in children's behavioral health issues. And in 2010, we started to meet formally around system of care strategies, which if you know that children's behavioral health is being transformed nationally around system of care values and principles, primarily because we know that children with emotional and behavioral challenges are encountering systems in all manner of contexts and different agencies, and each has its own way of responding to the child, and it's often very confusing for the family or child. So system of care brings all those systems together at the child and family level to try to make sense of all the services, to make sure that services are provided to children in school, in home, and in community, designed to keep the children in their community settings, and designed to be culturally and linguistically competent, because every family has its own culture, its own manner, and its own way of being an effective family, and we need to respond to each family differently. So we've organized our workforce around the system of care, which is a national framework. And over the years, over the past 20 years, the system of care researchers have identified that 5 major strategies, which you see on the screen here, are really important if we are to transform our system. And our workforce network is focused on strategy number 4, providing training, technical assistance, and coaching to workforce, the children's behavioral health workforce. And we envision the workforce in a very broad manner. It's not just paid staff, not just professional staff. It includes peer-to-peer supporters, peer-to-peer family supporters, peer-to-peer youth supporters, paraeducators in schools, people who don't get paid to be a support network to a child. So we envision the workforce in a very broad way. Our workforce has a mission and a vision that is very much in line with system of care. This vision and mission was formed with support from Joan Dodge, who Kim mentioned earlier, with her consulting and support. And this vision was not developed by me. It was developed by all the members of our workforce network. And we really envision a highly skilled and sustainable workforce, and I think we'll get to that sustainability piece when we look at this study. Making sure that not just the children and families are supported, but the people who work with them are also supported, and this is what Joan Dodge was talking about. When families encounter workers who are stressed or there's a lot of turnover, the level of care we know is of poorer quality, and we really have to have a good supported workforce. The mission of our development network is to ensure that the workforce is supported, that it's cross-sector system development, which means that people in schools, the workforce members in child welfare, in juvenile justice, in behavioral health, are all using a similar philosophy and approach, and that we're training cross-sectors and using evidence-based practices and technology that we know works. And we also have a set of core competencies that's been developed by our network, not by me, by all of the members of our network. It's been vetted by family members, family organizations, providers, and has really been a great functional document for us to use as we move forward. We are organized as a network with a leadership team that includes higher ed representation, state policymakers, the New Hampshire Children's Behavioral Health Collaborative Director and members of the collaborative, children's directors from mental health centers, the State Department of Education, family organizations. And then we have work groups, as you can see here, that are all focused on specific topic areas, including there's an evidence-based practice work group that is looking at cognitive behavioral therapies and promoting best practices around CBT and TFCBT, which some of you may know what that stands for, trauma-focused cognitive behavioral therapy. And then there's children's mental health center directors review our documents and have input into our work and our documents and our plans. We have a higher ed work group that is using the core competencies to crosswalk with programs of higher ed to make sure that social work programs, family therapy programs, education, special education programs are using the core competencies and system of care principles. We have a wraparound work group that has been working on a wraparound curriculum to be replicated throughout the state. We have an in-service work group that has produced over 13 modules that are on the collaborative's website. We also have a Youth Move peer-to-peer training work group that is made up of youth with lived experience who are developing a peer-to-peer training curriculum for other youth to work with young people who are struggling. We have a youth mental health first aid work group that is planning and delivering training throughout the state. A multi-tiered system of support school-based work group, which is focused on positive behavior support and mental health in schools. And so we organize our work around these different content area groups. These content areas were identified by the members and identified by gaps that we noted in our service system. And we also really pride ourselves in having authentic youth and family voice throughout our workforce. Family members and youth co-chair each of those work groups. They work together with us to identify needs and gaps. They are faculty on in-service modules and college curriculum. They have developed many of the programs that we are implementing now. And we work together really closely to make sure that youth voice and family voice is part of all of our trainings and all of our in-service and pre-service work. So it's, as you can see, the next slide shows you our core competencies document. You can download it on our website at the Institute on Disability, as well as the Children's Behavioral Health Collaborative website and the Endowment's website. Please do take a look at that. I think it's a really strong document. It's currently being revised to upgrade and update the cultural and linguistic competency standards. But we do hope that you'll use it in your practice and in your deliberations for yourself if you're a practitioner. We did find that stressors within the children's behavioral health workforce led our leadership team to really reach out and work with Dr. Antal to design and help him carry out a study of retention within the workforce system and really studying what the gaps and needs are of the workforce. So at this point, I would like to turn it over to Dr. Antal to talk about his study.
Good afternoon, everyone. Again, this is Peter Antal of Antal Consulting, and I was quite pleased after having worked for the last 10 or more years looking at various mental health issues within New Hampshire and trying to study the various factors driving systems and how change happens and doesn't happen, what the various factors are to partner with the Behavioral Health Collaborative to look at this particular issue area and get a better understanding of all these things that we've heard over the years about concerns that families and kids and also adults have raised about challenges in getting better when they have multiple turnovers in staff throughout the course of the year and throughout their treatment and management period. So we had a nice opportunity to take a much closer look at this and move from beyond simple anecdotes to putting some real numbers and some much more descriptive information to help us get a better understanding of the context of the problem and what were some of the issues that would help us better understand what actions we could take to address it. So overall, the purpose here was to gain a better understanding of these factors, document what some of the different impacts were that were critical to understand if we are to make effective decisions for reducing staff turnover, and then not only to identify some of those problems, but to also suggest a range of different methods that could be pursued by individual centers, by the state, by the national level to help turn this area around. We're pleased to have the different partners that have participated throughout this process. Involved a substantial amount of time over the past year from the Children's Behavioral Health Collaborative, Endowment for Health, Behavioral Health Association, community mental health centers, which were integral, as well as their staff, to providing a lot of information that typically has not been made available publicly in the past. The fact that they've all participated in this process has been monumental, as well as Joanne's leadership from the Institute on Disability to help bring all these pieces together. So the basic stages that we pursued was starting with a literature review on what we knew from the literature about staff turnover, what was the norm, what were the things driving it. We conducted a survey of the CMHC directors. We had all 10 CMHCs participate in the survey, asking questions about what they thought the barriers were to staff turnover, what they were doing to retain staff, other activities that were underway. We also conducted a survey of human resource directors, and 7 of the 10 CMHCs provided information on staff pay, voluntary staff turnover, benefits received, and a range of other factors that we looked at. And we also conducted a survey of staff providing direct services to children across the community mental health centers. And what's important to note, of the 335 potential staff that were of that initial sampling pool, we had about 73% staff participating in the survey and providing oftentimes substantive feedback. And then to wrap that whole process up, we then conducted a series of follow-up meetings with the community mental health center directors and other partners to review the findings of the study, basically do a reality check. Is, are the things that we're seeing consistent with people's expectations and understanding of the different issues that are going on? So just in general context, why is this so important? As I mentioned, a lot of my background work in New Hampshire was looking in the mental health area, and part of it was conducting 5 years of the statewide public mental health survey. And consistently over that time period, some of the most frequent concerns that families and youth had raised during that process were concerns about staff turnover and their access to staff that had training that they needed to pursue in order to actually help their youth and the family get better. So I just put a few examples here from the youth. So youth 14 to 17 responded to some of these questions. If they would keep some counselors and doctor for medicine for longer time instead of switching all the time. For families, this therapist would stop going away. Another one, he's been through 3 different counselors. They gave him incentive to stay. They get really good people, but then they seem to like they lose the good people. And another family offered more access to professionals in a much quicker fashion. It took us 4 to 5 months for an appointment for an intake. It took us 2 to 3 months from that to be assigned a counselor, and the counselor seems to be straight fresh out of school. She didn't seem to know what to say or do at all. So with that, we have some background information on historical trends and anecdotes, as I mentioned earlier, of both families and youth and providers being highly concerned about the consistency and availability of staff in general, as well as within specific disciplines. We have demands for childhood services increasing. Each year there's more and more kids, and the actual rate as a rate of the population of children has been increasing overall. Over the past number of years. Also during this time period, we've seen over the past year increases in waiting times, wait lists for services. So whereas critical services are often triaged and addressed within a day, those patients that are not in a kind of critical stage and needing immediate treatment are needing to wait a far longer period of time, anywhere from 10 to 70, 80 plus days before they can have an intake and get seen for services. In addition to that, one of the other things that came up during the course of this, the process of research, was a focus on documentation activities. And a common recognition that accountability is important, but then also what we found out was that staff are often spending 10 to 20% of their work week just doing documentation activities instead of directly providing services to clients. So these are all various issues that need to be balanced as part of a systemic review of how it is we're allocating resources, both financially and in terms of staff time and staff capacity, in order to best meet the needs of the youth that we're serving. So the core findings that we have as a result of the study. The largest one overall, and is not really a surprise to many, is that staff turnover disrupts quality care. And so we have a number of factors that we'll get into that more clearly specify what those underlying points are. There's a lack of service capacity in a range of areas that in general we're short across the board, and some areas drastically so. That these turnover rates vary substantively by different types of positions. There are very specific reasons why staff leave, where we found a strong majority of staff felt that these are the top 2 or 3 barriers that really they struggled with in terms of staying in their jobs. And on a positive note, when we combine what we learned from the research base and combine what we learned from the director interviews, there are quite a number of strategies that can be pursued, not only at the center level, but also at the state and potentially national level as well, that we can pursue in order to turn our activities around. So the first primary area, finding number 1, in terms of disruptions in quality care, the core impacts that we have in this area. We have lost professional experience as we think about staff turning over and leaving to find other opportunities. Lost opportunities to strengthen the care environment, and to this point, we had management supervisor staff talk about the amount of time that it took to provide training support for new staff, and oftentimes, one supervisor said that it took up to 115 hours to recruit, provide training, provide basic starting support for new staff. That there were declines in staff competency, experience, and productivity, particularly as new staff came on, where they did not bill for services because the staff was still being trained, but that staff member still had to be paid, so their costs relate to that. Sets of financial burdens for agencies, negative impacts on workplace culture. If you think about not only what happens when a person that you really care about within your workplace leaves, But when 2 or 3 all leave within the same time period and you have a close-knit staff, very strong implications for workplace culture, not only for those remaining, but the impact that that had for the stress and anxiety level for those remaining staff at those areas. Lost opportunities to integrate improved services. One of the telling things we had received from the director surveys was the concern that other community agencies were hesitant to refer clients to the CMHC because of the high turnover rate, that it was viewed that there was a potential risk in sending the client to the CMHC, and that they were not viewed as a valued partner in caring for the kids, some of the kids within that community. So these are some very telling things that have far-reaching implications, that when we talk about staff turnover, it's not just a matter of the direct finances and losing a new staff person, but that the implications across the board have multiple impacts. And ultimately what we're talking about is an ability to improve outcomes for children, youth, and their families. And so we know, particularly from the statewide public mental health survey, that outcomes for children and for families have really not changed substantively over the last 5 to 10 years. They've been holding typically 50 to 60% or so on different outcome areas. And part of that change, I would suggest, is related to our ability to retain high qualified staff that have the knowledge and experience to provide effective services to support these kids that have these very complex and challenging conditions. So I mentioned as one of the impacts the loss of professional experience, and so this is just one example that we have about what can happen over a 5-year period. So normally over 5 years, if we had everyone stay across that time period, we'd expect to see a 5-year average increase in experience levels. And what we're seeing, based on the different profession types, is that for 5 of these areas, they barely even managed to maintain 1 year of growth of experience over the course of 5 years. And for these last 3 areas, the functional family support, community-based, and MD psychiatrist, that overall as a workforce cohort, a group of people that are able to effectively deal with, support, manage, and improve the health of folks, that there's some very major, some strong major gaps in the opportunities that we have before us to improve services. Finding number 2, we have a lack of service capacity in a range of areas. So out of the 7 community mental health centers that participated in providing information on the human resource data, those served about 9,500 children across 254 staff from those 7 agencies. So if we look at what that rate is for that number of children served, we have about 14.4 clinicians per 1,000 kids served, 8.2 case managers, about 2 prescribers and other medical staff, 1.2 student interns under 1 other, and 0.3 for drugs and alcohol. So first point on this piece, when I went back to the community mental health center directors and asked them about, well, what's short here? And the consistent response with all these categories were short, that if they're thinking about the number of staff that they need directly to provide services per 1,000 kids that might come through their doors, all these categories are short. So we're already starting from a level of not having sufficient staff capacity to meet the basic mental health needs of the kids that are coming through the CMHC doors. On top of that, there are these issue areas where we're falling far short, particularly along prescribers and other medical staff and within the drug and alcohol field, because the drug and alcohol field affects so many within the youth, within the families, and affects the home life for all those kids that are within this system, that these are just some very stark areas that will need to be addressed as we move forward. Third finding, dealing with turnover rates vary substantially by area. So we had broken up where we had enough sufficient end size for each of the professions that we tracked as a part of the HR survey, what the turnover rates were across these different groupings. So we have the psychologists, found the support. A number of them were at least 1 in 5. The rate of turnover was about 1 in 5 on average per year. And in some areas where it was a little bit lower. So supervisory staff was about 8%, program directors 6%. One of the things that we noticed as a part of this review process was that there was a shift in the number of staff who were licensed versus non-licensed. And over the past 5 years, there was a notable shift in the CMHCs being much more likely to hire, try to retain non-licensed staff, and that the licensed staff were being more likely to move on to other venues. So this is another kind of important dynamic to pay attention to as we're considering whether or not we have a workforce cohort that is sufficiently trained and available to meet the changing needs of the child population. Finding number 4, primary reasons why staff leave. So we asked some similar questions of both the directors and the staff, and what rose to the top of the list for both groups was the low salary relative to cost of living, and then as well as documentation requirements that both sides recognized that the staff pay was not sufficient, that both sides noted that there were many years where there was no increase in staff pay, inability to provide raises when needed, and that documentation was becoming an increasing burden in terms of the ability for staff to provide the services that they need to provide for the kids they're served. In addition, from the director's perspective, they noted competition with schools and private practice as being a challenge, and then from staff perspectives, which were then viewing things from the client perspective, that there were limited community service for clients, and that to them was a major barrier on trying to provide effective services, that they didn't always have places that they could refer kids onto additional resources and services, which again is also a factor of experience and whether or not staff have the knowledge and background to know what those resources are, whether or not they are actually in fact available. So this issue of staff pay I had looked at a little bit more in depth to kind of find out, well, what is going on if we look across the board. And so we looked at median salaries across all the staff that we had enough information for, 2010 and 2014. And during that time period, it was about an 8.6% inflation rate, where in order just to maintain a basic standard of living, if you started in 2010, you would want to see your salary increase by at least 8.6% by 2014 in order just to continue paying for the bills that you had starting in 2010. And so this, of course, doesn't take into account changes in healthcare costs and all the other things that go up far higher than that. And what we found was, unfortunately, very dramatic. So across most areas, the cohort as a group, salary increases did not keep pace with inflation, and that for many of the people working with the community mental health centers, they were actually worse off financially 5 years into their job than when they started as a result of inflation. The exceptions to this were the MD psychiatrists and psychologists, but these two are kind of a unique case in that the availability of people within this profession is very low. And by bringing that MD psychiatrist up by 24% over that 5-year period, what was happening was that they were actually just putting that group on par with other psychiatrists within the region. So it's not like the psychiatrists are actually getting a lot more, they're actually getting paid more on par with what the market should be supporting within that venue. So they're getting paid about as much as they should be, but a lot of these other groups, there are some massive differentials, in some cases $25,000 or more, between people who have similar credentialing, who do similar kinds of work in terms of mental health care for target populations that get paid a lot less within the community health centers than they do within other sectors in New Hampshire. Finding number 5, there are multiple strategies to consider. We asked different centers what they were doing to retain staff, and what was interesting to note was that they all have kind of a lot of different unique ways that they pursue to try to retain staff. There was very limited consistency across the state. And one of the implications of that is that it's hard to figure out, well, what's really working in terms of how it is that we retain staff, what's the most effective mechanism, what's the effective way of resources to retain staff across the state. None of them cited regularly scheduled pay raises as a method as a retention strategy. We asked staff what they wanted. 50% or more stated that the following are critical factors shaping the likelihood of them staying for at least 3 or more years. So they said the top, regularly scheduled raises, cost of living increases, and loan forgiveness for federally underserved areas. In all, we looked at 48 strategies for retention that were reviewed by staff. Of these, 21 were rated as critical, at least 25% or more of the staff. 29 were identified as a major or critical influence by a majority of staff. So here we have areas where we had at least 50% or more of the staff saying that they had a view the strategy as being a major or critical influence on their decisions to stay with their agency for 3 or more years. And it's ranked ordered in terms of highest to lowest. As you can see, many of them deal with just costs of living. So regularly scheduled, cost of living, longevity, factors related to performance-based, the loan forgiveness or federal areas, opportunities, but there's other things that are non-financial in there as well. Opportunities for self-care by 74% of staff, more flexible work hours, improved health care coverage, opportunities for personal growth, paperwork support by 64%, working from home 56%. So whereas not all of these can be implemented on a regular basis by each individual center, that the idea and the hope is that individual centers can review this listing of strategies that are included in the report and figure out with their staff what are the strategies that are going to be likely most effective for their particular circumstances. I mentioned each center is different. While there's some commonalities that they have to deal with and challenges in terms of reimbursement rates from the different centers, what they can individually pursue, that there are indeed a list of opportunities that they can pursue. One of the things I wanted to share, actually before we get into that, one of the other things that we had looked at was the issue of decision making within individual centers, and so we had asked staff whether or not they, where the locus of control was regarding patient care at their center. Or most decisions about patient care kind of directed by their supervisors, higher ups within the center, or to what extent did the staff member providing services get to direct primarily the patient care. And so what we found fairly consistently that those centers where staff felt that they had a more direct locus of control over patient care, that those staff were less likely to cite a number of areas as being barriers and less likely to identify certain strategies as being a major or critical factor in their retention to stay. So based on the research, it's a strong suggestion, along with all these different strategies that we've talked about, that centers take a look at if there's different ways of streamlining or organizing how decisions are made around patient care from the staff perspective, and identify if there have been systematic events where staff efforts have been stymied by internal management policies, and whether or not there are ways of addressing that as people move forward. I did want to read one quote from the report that I think was kind of helped set the context for some of the challenges that staff have been dealing with. So this is from one of the people that participated in the staff survey. Working with a diverse client population is very rewarding and helpful to gain considerable knowledge and experience. As someone who has never struggled with school, college, or previous work expectations, however, I have yet to find a way to balance over the past number of years at the agency. Paperwork is time-consuming, and the EHR, or electronic health record, tends to be very slow and inefficient. So I'm caught up on paperwork, but I'm not meeting productivity expectations, which are also quite unattainable as it doesn't factor in no-shows and cancellations, which are out of our control for the most part. Additionally, the pay and benefits are almost insulting. I see an issue with having gone to school for 6 years to work in the human services field and still live paycheck to paycheck. So the research, in summary, highlights a number of areas in New Hampshire's approach to community and mental health care for children, where there are fixable breakdowns in our ability to make good decisions at multiple levels and pursue effective courses of action to ensure that we have an effective and strong cohort for workforce to help meet the needs of kids. There's a need to ensure there's an effective balance between addressing accountability concerns, the need for information to provide effective services, and time to actually provide that service. To mention, on average, staff are spending 20 to 40% of their work week addressing documentation concerns rather than focusing on the needs of the clients. There's a need to actively pursue a range of service and policy option improvements. Funding and accountability are two of multiple issues to address if the system is going to be strong enough to meet the growing demands that are placed on the various community mental health centers. We need to keep in mind that wait times for services are increasing, and New Hampshire continues to experience substantive gaps in staffing across the board, while children and their families are sometimes being put to the position of being the trainers for inexperienced staff. So with that, I wanted to take a small moment and ask folks to give a little bit of feedback. We have a brief poll to conduct, and you should be seeing a voting pop-up on your screen. And we'll close that in about 10 seconds. Good. So we asked the workforce issues identified in the study seem relevant to you. And 83% of our attendees say it's highly relevant, 13% fairly relevant, and 4% not relevant. Thanks very much for the feedback. It's helpful to know. And again, also encourage you, we'll have some contact information at the end of the presentation. If you have any questions for myself or other partners as a follow-up to this study, we're all happy to provide what answers we can. So following up on my comments about the need for multiple system changes and efforts to address this barrier, I've asked Joey Labarsky from the Seacoast Community Mental Health Center to share some thoughts on some of the reactions and responses from the community mental health centers on this topic.
Thank you, Peter. And as I get ready to begin, I just want to thank all the staff applicants who participated in this survey. Your feedback has been so valuable for us, and it's going to allow us to take next steps in how we approach this challenge. And I want to thank all those who are participating today as well. So first, I think it's important to note that association members need to continue their efforts to advocate for both policy and funding changes in order to support improving recruitment, retention, and overall work environments for community mental health staff. If we go back to what Peter just presented, the top 3 reasons staff cited were issues related to finances. Our staff need to have a livable wage in order to continue their work within the field, and we're losing great staff to higher paying markets. We also have to remember that these challenges are not just locally focused or center specific. These challenges exist across our field and across the nation. And how do we take this unique opportunity in New Hampshire and use this data to make cumulative changes for New Hampshire's working professionals and the families that we're serving? The association is going to be working with a consultant to gather current information on both staff recruitment and retention. The work with the consultant is going to be an ongoing opportunity to have an objective opinion on this issue, to identify areas in need of improvement in order to take meaningful action for the employees of the community mental health centers and other child-serving agencies. We need to take a look at what's working at other centers and agencies and how do we learn from each other. If we look at the staff at many of the community mental health centers, we'll find that we have folks who've been employed at the centers for 10 to 20 years and have worked in community mental health for most of their careers. And I think it's important for us to look at why is this? What's worked for these staff? And how can we use that as a foundation to build upon to attract other staff back to this working environment in order to make us the working environment of choice for those coming out of social service programs. Advocacy is going to be required. There's going to be required collaboration amongst the Children's Behavioral Health Collaborative, NAMI, and other advocacy groups and stakeholders in order to advocate for child-serving staff. We need to come together as child-serving organizations for a shared mission. When our workforce is stronger, we support a healthier community, which should be a shared mission by all of our organizations. We also have to recognize that the centers cannot single-handedly change funding levels or policies that mandate the burdensome levels of paperwork, but they do have the ability to improve the work experience within their individual centers. We had over 70% of our child-serving staff respond to this survey, so clearly this is an important issue to all of our staff, and we need to make sure we continue to be a voice for those staff. We need to create cultures and environments within our specific centers where staff feel their feedback is valued and reasonable action will be taken when they offer this feedback. We have to recognize, and I think it's important to communicate with our staff, that there are going to be a lot of things outside of our control. We have both state and federal mandates around documentation and how our services are provided that we can't change. But when many of us are coming together as a collective voice, that's a stronger voice than one person trying to do it on their own. And I think it's important when we start to look at our specific centers, what are the different things that we can do to enhance this experience for our staff? We need to look at things like the provision of supervision, how we support our staff toward earning state licensure, giving them opportunities for training in advanced practices and treatment modalities, and the ongoing consultation we provide around those learning experiences. And how within our specific centers do we create learning environments where both education and professional growth are encouraged and supported for our staff. Each center can work with their staff to identify and implement changes to the workplace culture that can improve the environment and the morale for staff. One of the things that happens so often is when we recognize that a challenge is occurring within our work environments or something needs to be addressed, we form committees or task groups. But one of the things we fail to do is involve those individuals that are most impacted by the changes we want to implement.
So at our specific centers, when we start to proceed with making changes to improve the environment for our staff, we need to involve our staff within that process. Have them be part of the committees, have them be part of the task groups, so when we implement change, it's actually change that's going to impact their jobs in a positive manner. Again, training opportunities, providing merit-based increases, and annual evaluations that have true value rather than just a formality within the workplace are opportunities for us to give genuine appreciation for the work that our staff does. In a field where burnout is so prevalent and vicarious trauma can occur for our staff, we need to make sure we're reminding our staff to use self-care, to encourage the use of it, and how do we bring fun back into a work environment that can be really stressful for our staff. It's important for us to continue to realize that productivity is a reality in a service fee-based system of care, but the clarity of expectation is critical. So many of us hear from our staff that productivity expectations are difficult to achieve, and so we need to, within our centers, look at what are the reasonable expectations for our staff and how do we assist them with understanding these expectations so they can be achieved. Our centers need to reevaluate our productivity structures, what can be done to develop structures that staff understand that they can in fact achieve and also maintain the physical health of the centers. We need to look at incentives for those who exceed expectations and how those can be very motivating for our staff. When we create realistic expectations for incentive achievement, this allows our staff to feel rewarded for the work they do, and in many instances allows our staff to no longer have to work 2 jobs in order to have livable wages to survive. We also need to invest in our staff's skills, continuing to offer trainings related to our staff's interests and training to support their work both clinically and administratively. How do we offer opportunities to support their work so they can feel that they can achieve it and sustain it in a manner that they can have a life outside of work as well? How do we support our staff to increase the confidence in the areas where they'd like to gain skills and advanced practices? And when we're looking at how to help our staff balance both the clinical and administrative tasks of their work internally, how can we use administrative supports to support our clinical staff in getting their work done? I think so often we hear from our staff and our clinical managers that they're so caught up in their paperwork or the expectations of productivity, they never can find the time to plan for their client sessions or within supervision really focus on clinically difficult cases with their supervisors. And so if we can find a better way to balance the administrative support within our centers so staff can get back to the clinical work and let that be the focus of what they do, I think we create an environment that's more enriching for our staff. And finally, we need to talk to our staff and to learn more about what we can do to make them feel valued. Again, I think it's really important for us to communicate with our staff that there's going to be realistic barriers that we're going to face. There's going to be some things that we can't change, but for those things that we can't change, how can we go about making it easier for them? We talk in therapy about the magical question, and I think it's really important that we bring the same magical question back to our staff, and that is, if things were different, how would they look in order for the environment to be better for you? What are your needs? What are your aspirations? What are your future goals? And as a center, how do we support you in achieving these things? We need to make sure at our centers we're creating environments where staff feel safe to share their feelings and that they're going to see action taken upon the information that they've shared. And we need to make sure not only do our staff feel supported at our individual centers, but that the larger system is supporting the work that they're doing as well. We need to remember to acknowledge staff and thank them for the work that they do. For those of us who provide clinical support, sometimes our jobs can be very thankless jobs, and the employers need to acknowledge the hard work provided by staff and support their efforts. We need to really bring attention back to self-care. That was one of the things that Peter cited as a strategy remarked by staff, that if they had self-care practices, it could make the environment better for them. So not only do we as clinical managers need to be good role models for our staff and practice self-care and take lunch breaks, but we need to remind our staff that it's important for them to take lunch breaks, to take breaks throughout the day, to set limits on how much work that they're doing outside of their core work hours, and to use their earned time rather than losing it at the end of a calendar year. We also need to remember that a few words can really go a long way toward making staff feel valued, whether these are emails, phone calls, handwritten personalized notes, the true expressions of appreciation that come from all levels of administration within our centers. These small efforts can often say very big things to the staff that we're working with. And we have to remember that this doesn't minimize our need to work on the larger issues. With more than 70% of our children's staff responding to the survey, it's clear that this is an important issue that we must work on together. We need to carry the message that these staff sent to us and make sure they know that they were heard. It's an important issue, and we have to take responsibility for the feedback that they've given us and take steps to make changes within the workplace. We need to own this, and we need to take action in order to improve the environment. When we create opportunities for our staff where they feel fulfilled within their work and they feel supported, we again become the workplace of choice for staff, and we have staff who feel supported, validated, and appropriately rewarded within their work. So at this time, I'm going to turn things over to Effie Malley so she can talk about some next steps.
Thank you, Jody. I wanted to start just by thanking our Community Mental Health Center staff, especially our children's staff, which serve such a vital strand in our state's safety net for children and families. So with these next steps, the primary next steps are related to raises and reimbursement. However, some initial steps are needed preliminarily in research. The first area I identified is about the cost to bring salaries to market, to fund cost of living increases, and to forgive loans for service in federally designated areas. And secondly, it's not just the cost of things, but what would the impact of spending these funds be? So increasing salaries, the impact on client outcomes and the cost of services, for example. Then once we have this information from the research, a next step would be to set up a public-private task force to develop policies, implement, and evaluate them. And then to develop opportunities for a statewide center of excellence for children's behavioral health. The importance of this can't be overstated. Professional development and promoting evidence-based practices is a big part of our state's building a system of care for children's behavioral health. Joanne earlier mentioned that it was one of the 5 keystone strategies of a system of care to develop workforce capacity. I'm going to introduce Kim, and she's going to bring us to our question and answer.
So we have a couple of questions and probably some more time if folks have other questions after hearing all the presenters. But the first one I'll pitch to Joanne. One listener wondered how they could get involved.
If you'd like to get involved, you can email me. And I think if you'd like to get involved in our workforce group, it's an open group. You can choose which work group you want to be on. And if you just email me or call me and our contact information is available, I would be happy to talk with you. If it's not on the slides, nope. So you can contact me at the Institute on Disability at UNH. Just Google it and you'll find it. My name will be up there as faculty. So we'd love to have more people involved.
Great. Sounds terrific. And then the next question I think is probably for Peter. So this is a question about the state's new 1115 waiver, which is focused in part on improving behavioral health care capacity within the Medicaid program. So the question is, in considering the report findings, what recommendations would you make to the integrated delivery networks that are a part of that 1115 waiver to address the workforce challenges in our community mental health centers?
First off, I think it's just recognizing the factors that the workforce plays within actually delivery of care, and that the recognition that we need to have it, we need to have it functioning well, if services are going to be delivered effectively and health outcomes are going to improve. As a part of that process, then, it's clear from these findings that the issue of pay and retention are very closely tied together. That pay is not the only factor, however, but should be one of multiple factors that are looked at. So my recommendation in terms of this study and next steps would be to look at creating some new knowledge around doing a pilot, say, with 1 or 2 regions, where you look at what effect does improvements in staff pay combined with improved decision making, combined with other factors that help staff to take better care of themselves, where there's better supervisory support, where staff are having to spend less time on training and more time on providing effective supports and outreach to the community. When you have those different factors at play, how much does that change in terms of not only staff retention rates and what does that do over the course of a couple years, but also to very closely track outcomes among people who the people who are being served by those staff. And so what we've been lacking so far, I think, in terms of our decision-making process across the board, is this overall understanding of when we make a decision to either pay a raise or not pay a raise, and how we allocate resources, or how we set rates for those resources at the state or national level, what impact that has down the line, and what are the different factors to look at. So this study delineates a number of different factors that should be looked at when trying to get a better understanding of these short and long-term impacts. And it's only once we have a better understanding of those short and long-term factors that we really truly can make a more informed decision about effective market-based pay and livable wage pay for staff, and how to allocate those resources, both financially and human, to best ensure that we have a sustainable and effective mental health system for our children.
Thanks, Peter. And I think Jody wants to add.
Well, and I think, again, when we look at the survey data and what was reported by staff, finances is a big piece of this. And I think there's going to be ways that, again, at the association level, we can look at advocacy to address how do we change funding streams to support that. But also, more simplistically, when we start looking at these integrated delivery networks and the relationships that they're going to need to form within their communities, how do we really use the shared resources that we have? Because I think sometimes one of the missed opportunities is the wealth of knowledge that we have among staff at community mental health centers, at other child and adult serving centers as well. So when these integrated delivery networks start to form their relationships with partners within their community, how do you find your experts on trauma or your experts on substance use? And some of those experts exist within our centers. And so you give staff another opportunity to really show and use their skills in a different way that they haven't been able to. And I think this is another way we can really show value to the staff that we have, the work that they do, the knowledge, and create new opportunities outside of just the day-to-day clinical work that they're doing.
And I think, kind of following up on that, one of the other things I've seen in other sectors, but still within the healthcare sector, but also in education and other areas, is that there's generally a lack of support for care coordination, that in order for a lot of this to work, it requires that there's a method for financial resources for actually supporting staff time, whether at the CMHC level or the community level, to make those connections, build those connections, and ensure that people are getting access to services they need. Those things take time, and frequently they're not incorporated as a cost when setting up reimbursement networks. So that'd be my other recommendation as part of the next steps.
Finally, the only other thing I'd like to add, this is Joanne, is that every integrated delivery network really look at children. They're not necessarily a required population. So, and we know that we can actually prevent mental illness or exacerbation of some types of disorders by working with children and youth at a younger age. So just on a very basic level, that would be my recommendation.
Yes, and I would add to that to include social service agencies and schools as part of your delivery network for serving kids.
So the last question I have here from the audience is challenging perhaps for us to answer since we don't have anybody represented here from the Department of Health and Human Services. But both of these questions have to do with the role that the Bureau of Behavioral Health will play in supporting and working with these efforts. And the participant says that retention has been an issue for over 30 years and that this is not a new challenge. And that at one time, the department and the Bureau of Behavioral Health specifically had a training unit similar to what DCYF has at the present time, and wonders if there are any efforts to create such an entity to assure that training is available statewide. So again, I'm not sure there's an easy answer to that since we don't have a panelist from the department, but maybe Essie wants to try to.
Yes, one thing I wanted to mention is that the Children's Behavioral Health Collaborative has such a wide network of organizations that do advocacy, but we also work very closely with the Department of Health and Human Services and the Department of Education. So we will be talking about this issue with our policy work group in the coming months, weeks.
Yeah, our hope with this report is, as you mentioned, that it's a long-standing issue. It's something that we recognize has been in play for a long time. Our hope is that we have clarified the short and long-term impacts that were only kind of partially known, I think, by a number of the people participating. So a lot of the folks who responded to the survey knew that these were issues. They knew it's not a good thing that staff aren't getting pay raises on a regular basis. They knew they were losing qualified staff. But I think when it comes down to that, making that hard decision about whether or not to make a staff level raise increase happen or to increase the rate increase, that without knowing all these different impacts that this has, long-term impacts for care and the ultimate health outcomes, that information is something that we just have not had. And I think needs to be a priority if we're going to make an effective, a well-running system that actually provides and meets the needs of the children in our care.
And I do take it as an encouraging sign that Commissioner Myers has made such a priority of behavioral health and set up a new division of behavioral health, or a renewed division of behavioral health. And we really welcome that move and the close collaboration that that represents between Katja Fox and the collaborative.
Great. Well, it doesn't look like we have any more questions from the audience, so I guess we'll wrap up a little bit early today. Thank you so much for joining us on today's webinar. If you'd like a copy of the report, you can access that from the GoToWebinar control panel under handouts, and we've also posted a number of handouts there, including the core competency document that Joanne had mentioned earlier. We'll also post the reports, both the summary and the full report, on the Endowment for Health website following today's webinar. And it'll also be available on the Children's Behavioral Health Collaborative's website, along with the recording of today's webinar. So again, thank you very much for joining us. We do have contact information here on this final slide for Peter Antall, so if you have any additional questions for Peter on the report, he really welcomes you to reach out to him. And then for more information on the collaborative, Effie Malley, director of the collaborative, her contact information is listed here. And then again, from that Community Mental Health Center perspective, we have both Jay Kuchar and Vic Topo, executive directors of their respective community mental health centers, who have been part of the planning and research team, and also welcome your calls and emails. So thank you again for participating in today's webinar, and we hope to see you at some of our upcoming work group meetings.